this, and they said, wait a minute, we want one of these too. So the Pete's folks developed one for the Children's Hospital. And they're both very well attended by physicians, residents, and students. Pharmacy students and medical students. The goals of these formal ADR conferences, and think about how you might implement this in the various environments you might be practicing. One goal is to increase reporting, because you're talking about ADRs once or twice a month. And so people say, oh yeah, when we go to that conference, I saw some pictures, I'm make sure I tell everybody about it. It creates an opportunity to discuss observed ADRs in a multidisciplinary forum. Provides those in training, and people like me, with better skills for noticing and reporting, because you talk about how it was recognized. You can provide educational material on drug-induced diseases. We have handouts sometimes at these conferences. Create an environment for interdisciplinary patient care discussions, kind of a duplicate of what I said above. And then if you see trends, you can talk about those and have that as a presentation. Here's how our conference is formatted. We talk about, hey, who's seen an ADR since the last meeting? People will bring up something that they've seen. We jot down the name, medical record number, the outcome, and the pharmacist, usually my wife, at these conferences will take all that down and play detective and get it into the recording system. Those reports are followed by a brief, short presentation. Pharmacy does almost all of these now. Allergy and immunology was originally part of this, and we do a ADR, and then we do a drug allergy talk, and an ADR, drug allergy talk. But they've gotten, the allergy and immunology part has gotten overwhelmed, and they kind of backed off, so pharmacy's doing some of those allergy type talks now as well. We've used flyers to educate people. And I'll get back to that conference in just a minute. I think I got a couple more slides on that. ADR fun facts. And these were actually posted in restrooms. We can't do this now because it won't let us put anything on the wall. But at the time we did this, in the ladies' bathroom, we put them on the wall directly above where you would sit and see it. In the men's bathroom, we set them directly above the urinals. So basically, you always kind of see this. That's been shown to be one of the best spots to educate people, believe it or not. In our ADR conference, I mentioned that we had topics discussed. I pulled this one up because I thought you might get a kick out of it, because this was done by Tricia Wynn, who is a pharmacy practice resident. You might recognize Tricia Wynn is now Tricia Brandon, one of the faculty members. And Jen Fleming, who's also a faculty member, was a resident at the time. And then there were a couple of pharmacy students as well. So, see, this has been going on a while. And great job with drug-induced fever by those guys. Remember, I mentioned that the other day is one that's really difficult, creates a lot of problems on the floor. But that one's actually been repeated a number of times. The objectives of this ADR conference, of that particular presentation, define the incidence of drug fevers, what's the most common causative agent, describe the mechanism, describe the clinical presentation, differential diagnosis, and then outline the management strategy. So with that set of objectives, can you see how valuable that would be to clinicians, helping them kind of be more aware of what you do when you suspect a drug fever? And all of the presentations we've done have a very similar set of objectives to it. We're talking about how often does it occur, what drugs cause it, and the mechanism of action of the adverse drug reaction is something that we've learned that physicians are really interested in. So we've always make sure we talk about the mechanism, how it occurs. And they're always got the edge of the seat when you start talking about that. And then how the patient looks, and then how you manage it. We always finish with that so they know what to do if they see one. Other kind of things, just to give you an idea of topics that we've covered. How you initiate warfarin therapy safely, ADRs with azole, safety issues with insulin. I said that potassium is probably the most dangerous drug used in the hospital. The second most dangerous is probably insulin. Because if that's done wrong, if there's a decimal point error, or you use U instead of units and that is mistaken for a zero, man, that's a tenfold error right there. Adverse reactions to neuroleptics, anticholinergic drug reactions. I did that one. Remember the other day when I gave you that infamous quote, which I really like? common things happen more commonly than uncommon things. Anticholinergic drug reactions happen all the time because there's so many drugs that have that as a part of their mechanism of action that you see that too much of a good thing, and you get guys laying in bed who just can't pee because of the anticholinergic effect in elderly men. People get dry eyes, anticholinergic side effect. Warfarin drug interactions, because there are millions of those, as you probably know. Oh, this was good with proton pump inhibitors as a risk factor for Clostridium difficile diarrhea. There was an article that showed that there was a relationship between overuse of PPIs and the development of Clostridium difficile diarrhea. Well, physicians and nurses in the hospital hate to have a patient with Clostridium difficile diarrhea because that entire room smells horrible. The patient is suffering. It's easily transmitted from bed to bed, so there's this infection control issue. It's potentially serious for the patient because if it's not treated quickly and properly, I mean, they get dehydrated and it's very serious complication. So when we, and at the same time we did this, we were having an issue with overuse of proton pump inhibitors, them continuing them too long. The big issue was patients were getting PPIs in the ICU for GI prophylaxis to protect their gut because they weren't eating. But then as soon as they got out to the floor, they began eating. You don't need the PPI anymore, but it was still being used, and they wouldn't discontinue it. The minute we did this, our proton pump use plummeted because nobody wanted to contribute to the development of Clostridium difficile. So these things have been really, really effective. Back when that issue came out about cough and cold reps in children, and all the labeling changed, and you couldn't use all these products in children anymore, I think that happened about 5 or 6 years ago. We did a special one on that to kind of advise physicians what to do. We've talked about sulfa allergies, penicillin allergies, cephalosporin allergies, HIV drug allergies, local anesthetic allergies, a variety of topics. We've done drug-induced pretty much anything. Right after the benzocaine incident, we did drug-induced hemoglobinemia. Pretty timely topic, right? Pretty much drug-induced anything. Now, if you ever get involved and wanted to do one of these, get that book, Drug-Induced Diseases. I mentioned the other day that Diane and I had a chapter in, because every chapter would make a great presentation. And it's all outlined for you, so make slides right from the chapters, and you've got a great talk, boom, right away. Very little effort, but incredibly useful. To show you that this actually, the goal of decreasing or increasing the number of reports worked, in 2003, the year before we started the conference, from the Department of Medicine, we got about 1.7 average per month ADRs reported. 1 year after we started the ADR conference, it was up to 4 per month. The current is about 8 to 10 per month. And these aren't, they're reporting real ADRs, not just side effects and things that are expected. These are things that are worth trending. So it was incredibly successful in getting more reports. Now, I always ask physicians this, and so I'll ask you guys this, and I'll use Augusta as a representative of the entire class with a raise of hands. If you, and remember our definitions of adverse drug reactions that you report versus side effects. If you saw a person on levofloxacin develop altered serum glucose, would you report that? If yes, raise your hand. Okay, that is reportable. And matter of fact, that's a great example of why that's so reportable, is because there was actually a quinolone on the market that caused this at a higher rate than the other quinolones, and because people reported it almost simultaneously within 6 months of the drug's release, it was pulled off the market. But it can occur with other quinolones, so you do want to report that. Okay? How about vancomycin causing red man syndrome? How many would report that? Raise your hand. Okay, about half the class in Augusta raised their hand. Most people will not raise their hand on that one because they say that's expected. Okay? If you give it. But here's the reason why reporting is a good thing. Because if you report it, and we see reports coming from a specific nursing unit, it's time for in-service to tell them again about the rate of infusion, that it's really important. And so it corrects some nursing issues by having that reported regularly. I'll help you out with the rest of them. How about linazolid thrombocytopenia? Yeah, we reported that. We saw 3 cases within the first 3 months of the drug coming on the market when we're using it. We got those reported. It's now in the package insert, because not just us are reporting, but other people saw it. Somebody with diphenhydramine getting drowsy, would you report that? No hands going up, because that's kind of expected. That's a side effect. We don't worry about that. All down the list there. Penicillin prophylaxis, I'll jump on that. Absolutely report that, because we want documentation in the chart. This person has a true allergy, so that never happens again. Okay, conclusions. ADR monitoring program is a very important role for pharmacists. Many methods can be used to educate and inform other healthcare providers about ADRs. Developing an ADR conference can improve knowledge base about ADRs and increase reporting. So keep that in the back of your mind when you're thinking about new programs you want to start when you graduate in whatever setting you're in. Bottom line, ADR monitoring reporting can improve the care we provide for our patients. The ADR monitoring is one of those priorities. You can see some of the examples how it changed how we took care of patients, and we prevented so many problems by identifying a trend, solving the problem, and preventing those reactions from happening again. I just put these down. Drug-induced diseases, I'll mention that again. That's a really good book to have on your shelf if you're interested in ADRs. Myler's Side Effect of Drugs is a book that's published regularly with their annual updates. Diane has been involved with those regular updates. She does updates on one particular chapter of the annual thing. She's done it for the last couple of years. So if you're interested in having something on your shelf, that's a good resource. So there's 2 good resources for it. And I don't think we talked about those first year, so additional references for your reviews. All right, guys, that's it. Any questions about ADRs? And we are done before time. Questions? Okay, if anybody has questions, email me. I'll send out answers to everybody. Should be fairly straightforward about what kind of questions I'm asking. It's kind of highlighting those things. Should be relatively easy exam questions. Again, my philosophy is I put on the exam. It's important. I want you to know it, so I'm going to tell you about it, all right? Okay, I'll see you guys. We might have some changes in the syllabus. Just an update in case I didn't tell everybody in this class. Diane had a little minor surgery yesterday. She had a basal cell carcinoma removed from her chin. It's all gone. She is cancer-free. The procedure was effective. But, they did kind of have to go fairly deep into her chin, and it's a wound that's there, and it's going to take a little time to heal. And so last night, she was really having trouble talking. And she goes, Rusty, I just don't think I can talk for 50 minutes. So I moved her lecture that's scheduled for Tuesday later, and I moved my medical writing lecture up to next Tuesday, which is kind of nice because then I can do medical writing 1 on Tuesday, medical writing 2 on Thursday, and then back to back. That actually is kind of better anyway. So I haven't posted that on ELC, but just Tuesday, expect to see me rather than Diane. She's doing really well, but she's very sore right now. So she's taking the day off. I'm trying to convince her to take tomorrow off because Monday's a holiday, and that'll give her a chance to get back up to speed. But still, I didn't think she's going to be ready to give a 15-minute presentation on Tuesday. So I try to be a good husband. Give her lots of TLC and reschedule her as needed. Okay, so we'll see you guys on Tuesday.